Welcome to the deep dive. Today, we're diving deep into something, well, truly fundamental: normal labor.
Utopia, yeah. It's a fascinating topic.
Absolutely. And you, our listener, have shared a fantastic collection of resources with us: articles, research,
A
notes.
really rich set of materials.
So, our mission today is to unpack all of that. We want to pull out the most crucial, the most interesting insights about this incredible process.
But without getting totally swamped in every single detail, right?
Exactly. Keep
Right.
it clear, keep it focused. So, okay, let's start at the beginning. How do the sources define labor itself?
Well, fundamentally, it's described as this beautifully orchestrated sequence of events.
Happening in the genital organs.
Right. All designed to expel the viable products of conception.
Meaning the baby, the placenta, the membranes.
Exactly. Expel them out of the womb, through the vagina, and into the outer world.
Got it. And the sources mention a couple of related terms too.
Yes, parturient. That's simply the term for a patient or woman who is in labor. And parturition, which refers to the whole process of giving birth, the entire event.
Right. And our focus today is specifically normal labor, Utopia. What makes labor normal according to these criteria?
Okay, this is really key. For labor to be considered normal or Utopia, it needs to meet several points. First, it has to start spontaneously, on its own, and at term.
So not too early, not too late, and not induced unless there's a reason.
Precisely. Then, the baby needs to be presenting head first. That's the vertex presentation.
Bed down, ready to go.
Right. The process itself shouldn't have what's called undue prolongation. It shouldn't take excessively long.
Ficresses smoothly.
And it should end naturally,
Yeah.
with minimal assistance or aids.
Minimal intervention.
And perhaps most importantly, the whole thing should happen without complications that could negatively affect the health of the mother or the baby.
That seems like a pretty comprehensive definition.
It is. And it helps us define the opposite, too.
Which is abnormal labor or dystocia.
Exactly. Any deviation from that definition of normal labor falls under dystocia.
So, like, if the baby isn't head first.
Yes. Or if there are complications that affect how labor progresses, or the outcome for mom or baby, that would be dystocia.
Okay. Now, something everyone wonders about: the timing. When does it actually start? The sources say it's pretty unpredictable.
Very unpredictable, generally speaking. It really varies from person to person, from pregnancy to pregnancy even.
But there's a tool people use, right? Nagel's formula.
Yes, Nagel's formula gives a rough guide, an estimated date, but it's definitely just an estimate.
And the stats on when labor actually starts relative to that date are quite interesting.
They really are. Only about 4% of labors actually start on the calculated due date.
Only 4%? Wow.
Yeah, but around 50%, so half, start within 1 week either side of that date.
Okay, that's more like it.
And about 80% will begin within 2 weeks before or 1 week after the estimated date.
So there's a wider window where it's quite likely.
Definitely. And then you have maybe 10% starting around 42 weeks and even 4% at 43 weeks or later. It really shows that individual variation.
So, Nagella's formula itself, how does it work? It's based on the last menstrual period.
Yes. The LMP, the first day of the last menstrual period, it's described as a pretty simple arithmetic method.
And it relies on a couple of assumptions.
It does. It assumes a standard 28-day menstrual cycle for the mother.
Which not everyone has.
Exactly. And it assumes a total gestation period of 280 days or 40 weeks.
Okay. And there are two ways to calculate it.
Yes. The sources give two common methods. The first one, take the date of the LMP, subtract 3 calendar months, add 7 days, and then add 1 year.
Can you give us the example from the notes? LMP, September 28th, 2018?
Sure. So September 28th minus 3 months takes you to June 28th. Add 7 days, that's July 5th. Add 1 year. The estimated due date is July 5th, 2019.
Okay. And the second formula?
Second way, take the LMP, add 7 days, and then add 9 calendar months.
Using the same example.
Yep. September 28th, 2018, plus 7 days is October 5th, 2018. Add 9 months, and you land on the same date, July 5th, 2019.
So two paths to the same estimated date.
Pretty much. Gives you that target window.
Right. So we have this estimate, but what actually triggers labor? What makes it start? The sources say it's complex.
Oh, definitely. It's not just one single switch flicking. It's a really intricate interplay of many different factors. A cascade, really?
What are some of the main players?
Well, there's the physical aspect, the simple stretching of the uterus as the baby grows, uterine distension. That stretching effect on the uterine muscle, the myometrium, seems to play a part.
Just the physical pressure.
That's part of it. But then there's a huge contribution from the fetus. and the fetal placental unit.
Okay, what's happening there? Hormones?
A lot of hormones. It's fascinating. There's this whole chain reaction involving things like CRH, corticotropin-releasing hormone, ACTH, hormones from the baby's own adrenal glands,
The
cortisol.
baby is involved in starting its own birth process.
It seems so. And then you have estrogen and prostaglandins involved in this initiation cascade, too. It's like an orchestra tuning up before the main performance.
Let's talk about some of those specific hormones. Estrogen comes up a lot. What's its role?
Estrogen is really multifaceted here. It actually encourages the mother's pituitary gland to release more oxytocin.
Which we know is key for contractions.
Absolutely. Estrogen also makes the uterine muscles more receptive, more sensitive to both oxytocin and those prostaglandins by increasing the number of receptors for them.
So the muscle listens better.
You could put it that way, yeah.
Yeah.
It also helps create better communication pathways between the muscle cells themselves, these things called gap junctions. That helps contractions become more coordinated.
Interesting.
And it doesn't stop there. Estrogen is involved in changes in the membranes around the baby, leading to more prostaglandin production, and it directly stimulates the contractile proteins within the muscle cells, makes them more ready to contract.
Okay, quite the busy hormone. What about progesterone? Isn't that the one that keeps pregnancy going?
It is, largely. Its role in starting labor seems less about a big drop in levels and more about a shift in the balance.
The balance with estrogen.
Exactly. The ratio of estrogen to progesterone changes, rather than progesterone just plummeting. And this shift is also linked to producing more prostaglandins.
Okay, so that ratio is key. And then prostaglandins and oxytocin are the real engines of contraction.
They really are. Prostaglandins are vital for both starting and maintaining uterine contractions.
And oxytocin.
With oxytocin, we see a big increase in both the number of receptors for it on the uterine muscle cells and the sensitivity of those receptors, especially in the lower part of the uterus and the cervix during labor.
Making the uterus super responsive to it.
Precisely. And finally, the sources also mention neurological factors playing some kind of role, though it's complex.
So once all these signals align, how do the muscles actually contract? What's happening at the cellular level?
Right, the contractile system itself.
Yeah.
It boils down to a few basic elements. You've got actin and myosin.
The proteins that slide.
Those are the ones, the filaments that slide past each other, causing the muscle to shorten. Then you need energy, which comes from ATP, adenosine triphosphate. There's also an enzyme called myosin light chain kinase, which is involved in activating myosin. And critically, you need calcium ions, K++.
Calcium is the trigger.
Essentially, yes. Think of it as the key turning the ignition for that actin-myosin interaction.
Got it. And I saw something about different receptors on the uterine muscle, adrenergic receptors.
Yes, that's interesting too. There are two main types, alpha and beta adrenergic receptors. They have opposing effects.
How so?
Stimulating alpha receptors leads to uterine muscle contraction, but stimulating beta receptors actually inhibits contraction, causes relaxation.
So a built-in regulatory system?
Kind of, yeah. This balance is important throughout pregnancy and labor. And understanding these receptors is also why certain medications can be used to either encourage contractions or relax the uterus if needed.
Makes sense. Okay, so before all that true labor kicks in, there can be some preliminary signs. False alarms, maybe?
Exactly. False pain, often called Braxton Hicks contractions or false labor. It's apparently more common in first pregnancies.
And when does that tend to happen?
It might show up a week or two before true labor in first-timers, maybe just a few days before in subsequent pregnancies.
And what causes it?
It's thought to be related to the stretching of the cervix and the lower part of the uterus, maybe irritating some nerve endings, like the uterus is just, practicing, warming up.
Okay. And then there's also pre-labor.
Right, the premonitory stage. This can start even earlier, maybe 2 or 3 weeks before true labor in first pregnancies, again, usually a bit closer to the time in later ones.
And the signs are less consistent?
Yeah, a bit more variable. It might include things like lightening, some changes happening in the cervix, and those false pains we just mentioned.
Lightning, that sounds intriguing. What is that?
Lightening is that sensation some women describe where it feels like the baby has dropped lower into the pelvis.
Oh, right.
It's often more noticeable in first pregnancies. It happens because the lower part of the uterus kind of pulls open around the baby's head, engaging it more deeply in the pelvis. It's a sign things are getting ready.
I see. It can make breathing easier sometimes, I've heard.
Yes, potentially, because there's less pressure up high on the diaphragm once the baby drops lower.
Okay, so those are the warm-up acts. How do we know when it's the real deal? True labor. What are the defining characteristics?
Okay, true labor pains are different. They are definite uterine contractions happening at regular intervals.
Regularity is key.
Yes. And crucially, the frequency increases, they get closer together, they also get progressively stronger, more intense, and they last longer.
Increasing pattern.
Right. True labor is also usually associated with show.
We'll come back to that. What else?
You'll see progressive effacement, that's the thinning of the cervix, and dilatation, the opening of the cervix.
The cervix is changing.
Definitely. The baby's presenting part, usually the head, starts moving down into the pelvis, its descent. And the bag of forewaters might form.
Okay.
And a really practical difference. Unlike false labor, true labor pains aren't typically relieved by things like having an enema or taking sedatives. They persist and progress.
Right, they mean business. Let's unpack show. What exactly is that?
Show is basically the expulsion of the mucus plug that sits in the cervix during pregnancy. As the cervix starts to change and stretch for labor, this thick mucus is released.
Just mucus.
Often, it's mixed with a small amount of blood. This comes from tiny capillaries in the cervix or the uterine lining breaking as things stretch. So that mucus plug mixed with a bit of blood, that's the show.
Got it. And the bag of waters, how does that form?
Right, the bag of waters. As the lower part of the uterus stretches and the cervix starts to open, the fetal membranes, the sac around the baby, can detach a bit in that lower area where they're not as firmly attached.
Okay.
So as the cervix dilates, the unsupported part of these membranes bulges down into the cervical canal, like a little pouch.
Filled with amniotic fluid.
Exactly. It contains the amniotic fluid that's in front of the baby's head. It can act as a sort of natural cushion and help with dilating the cervix, too.
Interesting. Okay, so we've covered the lead up and the signs. Now, the main event, the stages of labor. The sources outline 3.
Yes, 3 distinct stages.
Let's start with the first stage. When does it begin and end?
The first stage starts with the onset of those true regular labor pains we just discussed. And it continues all the way until the cervix is fully dilated.
Which is how much?
10 centimeters open. That's considered fully dilated.
And this stage is divided further.
It is. Into the latent phase, which is the early part, typically from 0 up to about 3 or 4 centimeters dilation. And then the active phase, which is usually from 4 centimeters up to the full 10 centimeters.
Latent and active. Makes sense.
This first stage is sometimes called the cervical stage because the main event is the cervix opening up.
And how long does it usually last?
On average, it tends to be longer in first pregnancies, maybe around 12 hours. For subsequent pregnancies, it's often shorter, perhaps around 6 hours. But these are just averages, of course.
Sure. And what's physically happening to the uterus during this stage?
The uterine muscle fibers are undergoing progressive retraction. This means they contract and shorten, but they don't fully relax back to their original length between contractions. They gradually get shorter and thicker, especially in the upper part of the uterus.
Pulling things upwards.
Exactly.
Yeah.
This upward pull is what actually draws the cervix open, causing that effacement and dilatation. The sources have figures showing this uterine muscle pull dilating the cervix.
And the different segments of the uterus.
Right. The uterus develops a distinct upper active segment, which is thick and muscular and does the main contracting work, and a lower passive segment, which is thinner and more stretched out, incorporating the cervix. This differentiation helps the process along.
It's amazing how the body orchestrates all that.
It really is. All that work in the first stage sets things up for the second stage.
Which starts when?
The second stage begins as soon as the cervix hits that full 10 centimeters dilation. And it ends when the baby is completely born, expelled from the mother's body.
Okay. Does this stage have phases too?
Yes, it's often divided into the propulsive phase that's from full dilation until the baby's head descends down to the pelvic floor. And then the expulsive phase, which is when the mother feels that strong urge to push and actively uses bearing down efforts to deliver the baby.
The pushing stage.
Right. The average duration here is about 2 hours for first babies, and often much quicker, maybe 30 minutes, for subsequent births.
And this is where the real power comes in.
Absolutely.
Yeah.
You have the powerful uterine contractions, but they're now combined with the mother actively pushing, which significantly increases the pressure inside the abdomen. These are the expulsive forces that get the baby out.
Okay. And then the third stage, what happens after the baby arrives?
The third stage starts immediately after the baby is born, and it ends once the placenta and the fetal membranes have been delivered.
The delivery of the afterbirth.
Precisely.
Okay, so we've mapped out the stages. Definition, criteria, onset, signs, the 3 stages. But there's another huge piece. The mechanism of labor. This sounds technical.
It is quite specific, yes. The mechanism of labor refers to this really fascinating series of movements the baby's head makes as it travels through the mother's pelvis.
Movements to adapt.
Exactly. It has to adapt its position and attitude, how flexed or extended the head is at each point to navigate the shape of the bony pelvis. It's defined as these changes in position and attitude as the baby passes through the pelvis and the pelvic floor.
Like the baby is solving a puzzle.
Kind of, yeah. A very intricate dance to find the path of least resistance.
And there are specific named movements.
Yeah, the sequence of principal movements, though it's worth noting some can happen simultaneously.
What are they? Let's list them out.
Okay, generally in this order: engagement, then descent, flexion, internal rotation, crowning, extension, restitution, external rotation, and finally, the expulsion of the trunk.
Quite a list. Let's break them down, starting with engagement. What does that mean precisely?
Engagement is the point when the widest transverse diameter of the baby's head, usually the bit between the parietal bones, has successfully passed through the pelvic inlet, that top opening of the bony pelvis.
So the head is truly in the pelvis.
Right. Now, interestingly, before it fully engages, the head might tilt a bit sideways. This is called asynclitism.
Asynclitism.
Yeah. Because the head is coming in at an angle, the main suture line on top of the head might be slightly closer to the front, the pubic bone, or the back, the sacrum, not perfectly centered.
Does it matter which way it tilts?
Well, if the back part of the head leads, posterior parietal presentation, that's apparently more common in first pregnancies. If the front part leads, anterior parietal presentation, that's seen more often in subsequent ones.
Why does it tilt like that?
It's thought to help the head negotiate the inlet shape, maybe presenting a slightly smaller effective diameter initially. A little bit of this tilting is normal, even helpful.
But too much is a problem.
Yes, marked or persistent asynclitism can be abnormal and hinder progress.
Okay. Next is descent. That seems straightforward.
It is what it sounds like, the downward journey of the presenting part through the pelvis.
Happening throughout labor.
Yes, it's a continuous process, but it tends to speed up during the active phase of the first stage and definitely in the second stage.
Does it start before engagement sometimes?
In women who've had babies before, yes, descent might begin even before the head is fully engaged. Usually, though, the head reaches the pelvic floor around the time the cervix is fully dilated.
What helps the baby descend?
Several things. The force of the uterine contractions and that retraction we talked about, the mother's pushing efforts in the second stage, and also the baby kind of straightening out its body shape after the membrane's rupture.
Okay. Then flexion. You mentioned this is about tucking the chin.
Exactly. Well, the baby's head starts somewhat flexed. Complete flexion chin right down toward the chest usually happens as the head encounters resistance.
Resistance from what?
From the cervix, the pelvic walls, or the pelvic floor muscles during descent.
And why is this flexion so important?
It's crucial for descent because it changes the diameter of the head that's presenting to the pelvis. It presents the smallest possible diameter.
Making it easier to fit through.
Precisely. The sources mention the two-arm lever theory. Think of the joint where the skull meets the spine as a pivot. Resistance pushes the back of the head down and the chin up, increasing flexion.
Mechanics at play.
Absolutely.
Yeah.
It's all about fitting the smallest part through the available space.
Okay, next up, internal rotation. This sounds like a major turn.
It really is. A movement of great importance, often essential for further descent. This is where the baby's head rotates within the pelvis.
Which way does it rotate?
Typically, the occiput, the back of the baby's head, rotates forward towards the mother's pubic bone. So if the baby started facing sideways, it rotates to face downwards towards the mother's back.
Why does that happen?
It's complex, influenced by the sloping shape of the pelvic floor muscles, the overall shape of the pelvis itself, the outlet is widest front to back, and maybe differences in flexibility of the baby's head and neck.
Are there things needed for it to happen properly?
Yes, prerequisites include a well-flexed head, good strong contractions, a pelvis shape that allows it, and good tone in those pelvic floor muscles, the levator ani.
Where does this rotation usually happen?
Most commonly, it occurs when the head reaches the pelvic floor. Less often, it might happen higher up in the cervix, and very occasionally right at the end as the head is crowning.
And the shoulders, do they rotate too?
Ideally, yes. If the shoulders don't rotate with the head, it can cause some twisting in the baby's neck. Often, the shoulders rotate simultaneously or shortly after the head.
Okay, quite a maneuver. Then comes crowning.
Crowning is that moment when the widest diameter of the baby's head stretches the vaginal opening, the vulva, to its maximum, and crucially, The head doesn't slip back between contractions anymore.
It's here to stay.
Pretty much. The head is truly emerging.
And how does it get delivered from there? That's extension.
Yes. The delivery of the head happens through extension. As the head emerges, it pivots under the pubic bone. Yeah, the downward force from contractions is met by the upward and forward resistance of the pelvic floor. This causes the head, which was flexed, to extend the neck arches back, allowing the face and chin to sweep over the perineum as the head is born.
So it's not just pushed straight out, it curves out.
Exactly. It follows the curve of the birth canal.
After the head is out, there's restitution. What's that?
Restitution is a small passive movement. Once the head is free, the neck untwists slightly.
Untwists from the internal rotation.
Precisely. The head rotates back about 1/18 of a circle in the opposite direction to the main internal rotation it did.
Right.
So the back of the head now points towards the mother's thigh on the side it originally faced.
Just aligning itself again.
Yes, correcting that twist in the neck.
And then external rotation. Another turn.
Yes, this is a visible turn of the head that happens because the baby's shoulders are now rotating internally inside the pelvis.
Ah, the shoulders are catching up.
Right. As the front shoulder rotates forward to fit under the pubic bone, it causes the head, which is already outside, to rotate externally another 1/18 of a circle in the same direction as restitution.
So the head ends up facing...
Facing sideways again,
Yeah.
aligned with the shoulders, which are now in the front to back diameter of the pelvic outlet, the back of the head points directly towards the mother's thigh.
Okay, head and shoulders aligned. Finally, expulsion.
The grand finale. Once the shoulders are in that anteroposterior diameter, the front shoulder usually delivers first, slipping out from under the pubic bone.
And then the back shoulder.
Then the baby's body flexes sideways lateral flexion, which allows the back shoulder to sweep over the perineum.
A sideways bend helps.
It does. And then the rest of the trunk and legs are born relatively easily, often also with some lateral flexion.
Wow, what an incredibly detailed sequence of movements. It's amazing it happens naturally.
It truly is a beautifully adapted process.
So while all this is going on, what's happening with the mother and baby's well-being during the first and second stages? How are they monitored?
Okay, in the first stage, the mother experiences those contractions. The pain often felt low in the front. Initially, they're maybe 15-30 minutes apart, lasting 30 seconds.
Manageable at first.
Often, yes.
Yeah.
But they gradually get closer, stronger, and longer. In the active phase, they might be every 3 to 5 minutes, lasting around 45 seconds.
And the cervix, how is that checked?
Cervical dilation is assessed, often described in fingers initially, like 2 fingers dilated, which roughly corresponds to centimeters, or measured directly in centimeters, aiming for that 10-centimeter full dilation.
And effacement, the thinning.
Yes, that's usually described as a percentage. So 50% effaced means it's half its original thickness. 100% effaced means it's paper thin. Sometimes the term rim is used when only a thin edge is left.
Okay. What about the baby during this first stage?
Fetal heart rate is monitored. During a contraction, the heart rate might slow down a little, maybe by 10-20 beats per minute.
Is that okay?
Yes, as long as it recovers quickly back to the normal baseline rate, around 140 BPM, once the contraction ends. It shows the baby is coping well. If the membranes rupture, contractions might intensify.
And the second stage, what's the experience like then?
Pain definitely intensifies. Contractions become very powerful, maybe every 2-3 minutes, lasting a minute to a minute and a half. Towards the end, they can feel almost continuous.
Relentless.
They can feel that way. If the membranes haven't ruptured, they often will now with a gush of fluid. Very rarely, a baby is born still inside the intact sac, born in a caul.
Wow.
Internal checks track the baby's descent and rotation. As the head comes down low, it puts pressure on the rectum, so the mother might feel an urge to push, like having a bowel movement. It might even pass some stool.
And the head emerging.
Initially, the head might appear during a push and then slip back slightly. But as the uterus retracts and pushing continues, it stays put, leading to crowning.
What about the mother's physical signs?
Understandably, she can show signs of exhaustion. Breathing might change, more perspiration, maybe facial flushing and neck veins becoming prominent during pushing. But there's often a huge sigh of relief once the baby is finally born.
I can only imagine. Okay, that brings us to the third stage, after the baby's birth. What's happening then?
Right after birth, the uterus shrinks down significantly, maybe to about 20 centimeter top to bottom. The upper part becomes really thick and firm, while the lower segment is thin and floppy.
And the inside?
The cavity reduces dramatically to just hold the placenta in membranes. Crucially, the area where the placenta was attached shrinks.
And that helps it detach.
Exactly. As the site shrinks, the placenta, which doesn't shrink, buckles and starts to peel away from the uterine wall. This separation happens in the deep, spongy layer of the lining.
Are there different ways it detaches?
Yes, two main mechanisms described. Central separation, the Schultz method, often starts in the middle with blood collecting behind it, or marginal separation, where it starts detaching from the edge.
And what stops bleeding once it separates?
The main thing is the powerful contraction and retraction of the uterine muscle fibers. They act like clamps, squeezing the blood vessels shut where the placenta was. It's a natural hemostasis mechanism.
How long does separation usually take?
With standard management, usually around 5 minutes. You can feel the uterus become harder, more rounded, maybe feel a bit higher in the abdomen. Sometimes a little bulge appears above the pubic bone.
And then it comes out.
Often, yes. There's usually a period of watchful expectancy, maybe 15, 20 minutes, just waiting for spontaneous expulsion, sometimes helped by gravity or maternal effort.
What if it doesn't come out on its own?
Then assisted expulsion might be used. One method is controlled cord traction, gentle pulling on the cord while stabilizing the uterus. Another is fundal pressure pushing on the top of the uterus, but only when it's firm.
Okay. And after the placenta is out?
Uterine massage might be done to help it stay firm. Often, medication is given, usually oxytocin, sometimes methergine, as an injection to ensure the uterus contracts down well and prevent excessive bleeding. Oxytocin is often preferred for its effectiveness and fewer side effects.
Right, to prevent postpartum hemorrhage.
Exactly. Securing that final stage is crucial.
It truly is remarkable. Thinking about all these incredibly precise, coordinated processes involved in what we just call normal labor.
It really is. From the subtle hormonal shifts starting things off
Yeah.
to the complex mechanics of the baby's journey right through to the final stage.
It absolutely highlights the incredible resilience, the power, of the human body. Just amazing. What's a final thought you'd like to leave our listener with today after this deep dive?
Well, considering this detailed, finely tuned natural process, this sequence of events that's evolved over millennia, it really makes you think, doesn't it? In our modern world, with various possible interventions in childbirth, a profound question arises. How do we best balance utilizing helpful medical support when needed, while also deeply respecting and, where possible, facilitating this inherent powerful physiology of birth? Perhaps exploring more about physiological birth principles and the evidence around interventions could be a really valuable next step for anyone wanting to understand this balance better,